Today we're going to focus on sustainability. Many of you have been implementing your QI improvements, and we don't want them to just be implemented. We want to provide you with some resources and some direction about sustainability, and we are very fortunate to have Deb Kilday join us today to speak on that. Deb is with Premier Performance, and she is currently the manager with Premier, and it's actually, she serves as the Premier subject matter expert for women's and infant populations and works and coordinates the consulting programs for women and infants, perinatal collaboratives, and the Premier Perinatal Safety Community. Deb is responsible for the development of perinatal-focused analytics and business intelligence to advance opportunity identification and process reengineering that is innovative and transforming how we look at maternal-infant outcomes data. Deb's also a nationally recognized speaker, research, and subject matter expert in women and infant populations, and is recognized for quality improvement and implementation science expertise. He works in collaboration with lots of national and thought leaders, and he's worked with ACOG, AIM, A1. Deb's also been instrumental in developing e-learning modules focused on implementing the National Maternal Safety Bundles. Ms. Kilday holds a Bachelor of Science in Nursing and a Master of Science. She's also, the Master of Science is Nursing, Leadership, and Organizational Management. She serves on several national committees, including the National Quality Forum, Perinatal and Reproductive Health Project, Perinatal and Reproductive Health Standard Committee, Alliance for Innovation on Maternal Health, that's AIM. And also she's been also supporting us here in GaPQC. So Deb, we thank you for joining us today, and we'll turn it over to you. Anything else that I haven't added, please feel free.
My goodness, thank you so very much for that very kind introduction. I don't quite see the PowerPoint slide up yet, so in waiting on that, I just wanted to sort of give a little bit of background on myself for those of you that don't already know. I heard some voices during the opening of the call and names that I've recognized from my past. I have been in the state of Georgia for a little over 20 years, where much of my clinical practice has been maintained, and have a very strong allegiance to the state of Georgia. So very excited and feeling very honored to be part of this call today. I'm going to see if I can change this slide. I know that I was told it might be hard, and you were right, so we'll have to go to the next slide. There we go. There's some brief objectives there for you to review, and clearly at the end of the day, in addition to these objectives, the hope is that we can learn how to make sustainable change through the use of reliable implementation strategies, and hopefully together we can continue to make a positive difference in the lives of mothers, babies, and our communities. On the next slide, I wanted to provide a little background on the organization that I currently work for. I've been with Premier for about 5 years, and there are very strategic reasons for that transition. Most importantly was data and the ability to scale change to thousands of hospitals. Premier is a healthcare improvement company that is uniting an alliance of about 4,000 U.S. hospitals and about 165,000 other providers and organizations. So our breadth and reach in the healthcare improvement world is rather large. As an industry leader, Premier has created one of the most comprehensive databases, and it has actionable data that gives us clinical practices and efficiency strategies. We have award-winning technologies that helps our members really collaborate more efficiently together. We run very large-scale collaboratives, and I've outlined a few on the bottom of this slide. That one of our collaboratives, our Quest Collaborative, over the last few years has helped to save $18 billion for our members through this methodology, impacting over 200,000 lives saved, as just an example. On the top, I changed the slide at the last minute because today, which I'm pretty excited to share, is Premier launched our nationwide Bundle of Joy campaign. So Premier has been involved in maternal infant health for a very long time, but we have formally engaged with a nationwide campaign to scale advancements in maternal health care through our very wide platform. And it's really designed to raise the bar on quality and safety and cost for mothers and our babies. So I'm pretty tickled to share that. If anybody wants any additional information, happy to provide it. We'll skip to the next slide. So why are we here today? Well, we're here to talk about change. And change happens continuously. We all know that. But why do we need to change in healthcare, and why do we need improvement? Understanding why is really the first step in making change. While all changes do not lead to improvement, all improvement requires change. The ability to develop and test and implement change is essential for any individual, group, or organization that wants to continually improve, and hopefully what we'll cover today. On the next slide, our why starts at the beginning with preventable harm and death. In 1999, we learned that from the Institute of Medicine that approximately 100,000 people were dying every year from preventable errors in our hospitals. This was a widely touted analysis in the documentation of to err is human. And this was really the silent spring of healthcare. It grabbed the headlines revealing serious, deadly problems within our healthcare systems. It turns out that that announcement was really part of the good old days, according to newer studies, like one published in the Journal of Patient Safety, that likely 4 times more people die from preventable errors throughout the U.S., as many as 440,000 a year in that particular article was outlined. The Institute for Medicine's experts had very little concrete information used to estimate the extent of errors in our hospitals. With innovations in research, we've been able to identify them far more reliably. And my guess is if we have an additional publication, that number is going to actually climb. These people are not dying from illness that caused them to seek care from the hospital in the first place. They're dying from mishaps that could have been prevented. What do these errors look like? A sponge left inside a surgical patient. That a sponge left inside a patient we know could be very agonizing for that person and could lead to death and harm. Medications injected, for example, a baby's IV, having the wrong calculation, maybe that of a 200-pound man, leading to its death. There are so many reasons. None of these errors occurred intentionally. But why did they occur in the first place? And let's focus a little bit on pregnancy. We know in 2011 more than a third of pregnancy-related deaths were determined in California to have good or strong reasons for being preventable. We're learning as we start to dive into the data, which we know is almost non-existent. We're really starting to scale up in the U.S. But what we've identified through the CDC and through a 9-state review of maternal deaths, that actually over 60 and upwards of 70% of maternal deaths that occurred in those states could have been prevented with reliable strategies in place. Just this year, just about 4 weeks ago, Tennessee provided some insight on their maternal mortality review. On 85% of those deaths reviewed were deemed to be preventable. So we're here today in the state of Georgia to ask, really, where are we in terms of preventable harm and death? And that's part of the reason in why we need change. On the next slide, it's just sort of my illustration, and I'm sure all of you can appreciate it, that, when death occurs, one at a time silently, it seems to warrant less attention than those that happen in dozens or hundreds or thousands. I'm certain that if a 747 crashed twice a day, which is really what happens in terms of an annual preventable death rate in healthcare, then there would be a lot more attention than what it is receiving. That's even more true when it comes to maternal death and harm. It's not something that we've measured very well. It's happened a little at a time, and it's spread over the country, and therefore it really hasn't caused the attention that other events do. On the next slide, this is some drill down on statistics that I'm sure many of you are very familiar with. Briefly cover just to make sure that we're all on the same page. The U.S., we have about 4 million births a year. So that's 4 million women and at least 4 million babies. So 8 million people a year are impacted by maternal health. The maternal death rates over the last 20 years are 2 times higher than they have been in the past. And according to the CDC, the severe maternal morbidity rate is upwards of almost 200% in terms of an increase over the years 2003 to 2014. Disparities in the maternal population is quite evident. African American women are 4 to 5 times more likely to die than any other racial or ethnic group, and this is without regard to social or economic standing or whether or not they've received prenatal care. Another alarming statistic is 64% of the deaths are occurring in rural areas of our country, and part of that is due to the dwindling resources available for women who have to drive hours and hours for care or to find a provider, whereas 20 years ago it was the urban areas that were actually having most of the maternal deaths. The next slide is just a drive home. I mentioned this statistic a little earlier, but I thought I'd show it to you on a slide from that 9 state committee review of their maternal deaths. And again, overall, they determined that 63% of the deaths were preventable. But take a look at cardiovascular conditions and hemorrhage when they reviewed those cases. And that's really, again, part of the elements that I wanted to share with you today. So what are we doing about it? On the next slide, as a nation, we've been busy. It's not as if it's an unknown. There have been some very admirable efforts that have gone on over the last decade. Some of those efforts I've worked with some of you on in the state of Georgia at individual organizations. But with the recognition of the need to reduce maternal mortality and morbidity in the U.S., agencies have been developing strategies for many years with the intent to really fix health care and provide safe health care for every woman. This slide has the Council on Patient Safety and Women's Health Care, which is probably the most notable of these agencies that have really formulated the work. The Council on Patient Safety was established by ACOG to bring together all the different disparate organizations, professional organizations, to the table to develop standardized, reliable strategies around leading causes of harm and death to women. And you can see on this slide, and when you look at some of those organizations, clearly they haven't missed the mark on many, and actually there are far more than are listed on this slide that sit at the table. I sit on the table at the Council on Patient Safety and Women's Health Care as a premier industry member and serve on several bundle development committees. Those bundle development committees are really quite extraordinary. These are consensus-based, and once approved, these bundles go out to all of these organizations listed as a reliable method or measure on how to implement safe strategies at every hospital. ACOG additionally received funding through the Maternal Child Health Bureau and HRSA to establish AIM, which I'm sure all of you are very familiar with. AIM is the alliance of organizations that are charged with promoting consistent and safe maternal care. And the slide of all the organizations that sit around the Alliance for Innovation's table is massive. I mean, they have really engaged state, professional, and healthcare organizations to help support this effort. They initially started with about eight states, went up to 13 states, and has been quickly growing over the last 4 years with an additional funding by HRSA to target all 50 states, including Georgia, as we're here today. So very proud to see Georgia in this group and engaged in implementing these maternal safety bundles that have been developed. On the next slide, there's another reason for why. So there are a lot of patient advocacy groups that sit on the Alliance for Innovation program. There are a lot of groups that have a lot of reach to legislation, federal agencies, and even within our media agencies. There's been television news reports with spotlights on maternal mortality as an American crisis, sharing tragedies from patients and families and their perspectives. There's also been a lot of media publications over the last couple of years highlighting the need to focus on maternal health. You likely heard or read about the USA Today articles where scathing reviews were published. It's a series, I think we're up to 4 now, on how American hospitals are failing our mothers. The USA Today series has placed a public spotlight on the need to make changes within our hospitals, calling some of these hospitals out by name and publishing some of their data. They have really positioned hospitals as organizations that need to do a better job in supporting mothers and babies. On the next slide, there's some additional impetus into the why. To address the challenges, we know that means that we have to reform. And with publicity, there also comes additional accountability and federal and state agencies asking why. So on this slide, I just put up a few of the legislative actions that have been occurring. 2 of the mandates on this slide have become law. They were passed in December. These bills direct or these 2 new laws direct the Department of Health and Human Services to establish programs to support states for the purposes of reviewing pregnancy-related deaths, establishing and sustaining maternal mortality review committees, ensuring that state departments have plans for ongoing healthcare provider education and disseminate their findings and implement their recommendations to these findings. They also have outlined the need to have case abstraction and provide public disclosure for information in state reports. So those are the 2 laws that were passed in December. But there are more, and again, I only have a couple more on this slide, but they are very pointed. There is bipartisan legislation in both the House and Senate aimed at states to mandate the review and disseminate the findings of pregnancy-related and pregnancy-associated deaths and complications. The MOMS Act in the Senate specifically outlines states and hospitals' need for implementation of AIM maternal safety bundles and to provide support for outcome measurement. The Ending Maternal Mortality Act calls for a national plan to reduce the rate of maternal mortality, and each plan must address specific issues around mortality, particularly in labor and delivery that result in short and long-term health consequences. The last blue picture there is in the fall, the House Ways and Means Committee put together an investigation to determine the reasons for maternal harm and death in this country, and they actually asked for the data from an unknown, but it's probably over 100 hospitals and or systems, asked specifically for what they were doing around maternal harm and death and complications, and asked for their outcome data associated with that. So we don't have that report yet, but we feel that that's probably a pretty instrumental committee that's reviewing the why behind death in the U.S. On the next slide, why has all this death and harm happened and slipped under our noses without anybody noticing over the last 20 years? What caused this change? There's a lot of contributing causes. We could all read the data. There's a lot of articles that support one reason or another. But the bottom line is that the layers are pretty deep, and not one problem or one solution is going to solve the problem. Variation in care practices is clearly one of the leading indicators as to contributions for higher rates of mortality and death. We know that we're all pushing towards checklists and quality improvement tools and collaboration. We did a review within our database. Premier has a database of over 20 years of all payer claims data. And we did it in all diagnosis codes. And the number 1 and number 3 reasons for variation, highest costs related to variation in care, were vaginal deliveries, number 1, and then cesarean sections. And we all know that that's an attribution to a single hospital admission, and when combined, they lead by double in cost and variations of care compared to any other diagnosis code. So that alone is a leading indicator. We could talk about a lack of awareness because a lot of us didn't know. We didn't have knowledge because, again, it happened a little bit at a time. Clearly, our communities didn't have knowledge around the cause or the causes related to harm and maternal death. There is a lack of comprehensive data. We just mentioned that. The federal government is really putting some strategies in place to begin measuring that, and of course USA Today is publishing what they can find right now. We know that when we start to measure things that rates go up, so the problem may get worse before it gets better in terms of what the data says. So on the next slide, what is the answer to reducing preventable harm and deaths in our mothers and babies? If there are so many contributing causes, how do we fix it? And again, the Council on Patient Safety and Women's Health Care and the Alliance for Innovation program and the state collaboratives are really doing a wonderful job in trying to wrap their arms around what a part of that answer might be, and it's implementing standardized clinical practices and processes. So on the next answer, what are standardized clinical practices and processes? Well, the answer really resides in the need for high reliability in healthcare. High reliability organizations are those that have exceptionally and consistent methodologies in accomplishing their goals to avoid catastrophic errors in an environment where normal accidents can be expected due to risk factors and complexity. Hospitals are incredibly complex places. We have a high hazard domains for extended periods of time. The concept of high reliability is really attractive for healthcare due to the risk of significant and even potentially catastrophic events related to failures in our processes. Sometimes people interpret high reliability as meaning it's an effective standardization of our healthcare processes. However, it really means going beyond standardization. It's better described as a condition of persistent mindfulness within an organization. We'll talk about mindfulness a few times in this presentation. High reliability organizations really cultivate their resilience by relentlessly prioritizing safety over performance. High reliability is a systems thinking, and they use that to design their safety. And they're keenly aware that safety is an emergent rather than a static property. There are several attributes to processes that I placed on there: preoccupation of failure, reluctance to simplify, being sensitive to organizational operations, having a clear commitment to resilience, and deference to expertise, meaning making sure that those that implement the work are included in any process change. Throughout this whole presentation, all of the resources and references used are going to be provided at the end, including high reliability. But high reliability really means taking those keen processes, taking that organizational collective mindfulness, and making sure that the organization itself uses those attributes to discover and manage their events to produce reliability. On the next slide, this is one of those why questions for myself. So we expect high reliability in almost everything else that we do. We clearly wouldn't have a nuclear power plant in Georgia if we thought that it was leaking radiation to our communities. Of course, we know Boeing right now is experiencing what happens when there's a question in the reliability of their planes. I get on a plane 2 to 4 times a week. Clearly, I would not get on that plane if I thought I was going to fall to my death. I drive over a bridge expecting it not to fail. I buy food expecting it to be free of harm. We drink a glass of water not expecting it to produce any kind of illness or effects. And generally, when I go to buy a car, I will look up the reports related to the reliability of that car, and I certainly wouldn't purchase one with known failures in reliability. The next click, please. So why do we have hospitals separate from what we expect in every other segment of society? Everything else requires reliability, yet in healthcare we just gave a very brief overview of how reliability has failed and how it's impacted lives. So that goes to my next slide on what do we need to do, and that's the purpose of this webinar. How can we implement reliable practices? How can we implement these changes and achieve the desired change? Clearly, sustainable change is not easy. If it were, we would not be on this call. On the next slide, I've provided 11 tenets of a safety culture that was provided by the Joint Commission. Safety culture is the sum of what the organization is and does in the pursuit of safety. In essence, any leader who is committed to prioritizing and making safety visible every day, a part of everyday actions is critical to creating a true culture of safety, and our leaders must commit to creating and maintaining this culture. A safety culture is achieving collective mindfulness, as I mentioned earlier, where everyone in that organization works together individually and as a group, and in each strategy we are keenly aware that even the smallest failure of our safety protocols or processes could lead to harm. So the Joint Commission tenant safety culture there, they've outlined all the attributes associated with leading towards a safety culture. And if you're an accredited organization, your teams are probably aware of that. Your leadership and quality teams are probably aware of that. But it might be useful to share with your perinatal teams as well. On the next slide, and it's just sort of to drive home that changing organizational processes are comparatively easy when we develop checklists and processes and protocols and orders and guidelines. I mean, we can do that. We know how to do that. AIM has accomplished much of that for us, right? They've provided us with some of those bundles and education and information. But it's the organization's culture and interlocking, overlapping set of goals and roles and processes and values that really seem to hang us up. And quality improvement strategies are not well disseminated to teams expected in making changes necessary for improving and gaining desired goals if we ignore the culture within our organizations themselves. So on the next slide, in healthcare, quality improvement strategies are used as the framework to improve the way we deliver care. Processes have characteristics that can be measured or analyzed or improved or controlled, and it includes continuous efforts to achieve stable, predictable results. And continuous efforts is really a key driver in implementing change. We do this in order to reduce our process variation and improve our outcomes both for patients and healthcare organizations. And this is what we do in order to achieve high reliability. It requires the entire organization to really be involved from the top all the way down. The evolution in the United States around quality assurance has occurred where there was an emphasis on inspection and punishment for medical errors, or the bad apple theory, to quality improvement, where now we ask, how did the system fail to support the error involved, and how do we support our team members to ensure that that error does not occur again? There are 4 quality key principles when looking at successful quality improvement programs, and they focus around quality improvement work as systems and processes. That we focus on patients clearly as any strategy. We want to make sure that the work meets the expectations of our patients, their families, and the community. They focus on being part of a team. At its core, that quality improvement is a team process, And of course, it focuses on use of the data, which is the cornerstone of quality improvement. So on the next slide, there are many quality improvement methodologies available. I mean, you can just look them up. There's a lot of strategies. I put 3 of the most common platforms on this slide. The IHI model for improvement, Lean Six Sigma, and Lean Six Sigma are quality improvement tools that stand alone, or they can be combined together. The most common framework was the IHI model for improvement. It's really simple. It uses a rapid cycle process. What are we trying to accomplish? How will we know that change is an improvement? And what changes can we make that will result in that improvement? But again, with the introduction of other performance improvement methodologies, there's been a combination of some of these efforts, which is better, Lean or IHI. Well, IHI decided they would make an IHI-QI framework, which combines both of these strategies. And I listed at the top of this slide, and I'll use this over the next series of slides, on what are the key drivers from each one of these frameworks. Well, they all include forming a team, setting the goals, establishing measures, testing change, implementing change, spreading that change, and lastly, how do we sustain that change? So on the next slide, we'll talk about the team. Not one of us can implement change in isolation. We know this requires the help of others. Some of the processes and theories around change management seem pretty straightforward, but you would be amazed at how just missing one element, like structuring a very reliable team that's going to help you with whatever strategy you plan to change, will make the difference in its success or failure. It's critical that you get all team members on board early in the process in order to build a strong foundation and drive this project forward. An effective team should include members representing 3 different kinds of experts within your system and organization: system leadership, technical expertise, and your day-to-day leadership. There may be more individuals on the team with different kinds of expertise, but one or more individual with expertise in these areas should be represented. On the next slide, this is one of my several pearls that I'll share with you as we go through, and a little bit about my evolution in quality improvement. I mentioned changing a culture is difficult, and getting an organization and providers in the various departments on board is really quite a challenge. It's not an easy path. The inclination is often to just push through the resistance and sometimes try to get things done on your own or with small groups. While this may have an immediate impact on some processes, my experience is this will not lead to sustainable change and can lead to misunderstandings, feelings of resentment and division between parties. Not everyone will be on board at first, but it's very important to have everyone invited and at the table to hear the message and have input to avoid alienating members critical to long-term success of your project. I put N of 1 there because I actually, very early in my formative years, was called the N of 1. You try to do it by yourself. That's not a compliment. You need to learn how to work as a team. The importance of leadership on the next slide. I really want to underscore that when undertaking any quality improvement project, it's critically important to have organizational leadership at the table early on. They're positioned to drive the organization's actions by setting and committing the sustainability of desired goals. It's great to have that unit leadership on board, but that unit, that small team that has the idea, that wants to implement the change, must enlist the support of their executive team. The executive team leaders play an important role in setting priorities, providing structure in the improvement effort, and modeling the core values. It's very often when I take on an improvement effort for our hospitals across the country, I will take the mission and vision of the organization and infuse that within the vision of the particular project. They act on your recommendations, and they end up becoming the advocates for supporting the changes in policies and allocating the much needed resources. They need to understand why, and selling that message to your executive team is really one of the first big wins you will have in launching your project. I'm going to circle back again on the next slide to the key message. We are striving for high reliability and, most importantly, collective mindfulness. Everyone needs to understand their role in preventing harm. It starts with your quality improvement, but it's shared throughout the organization. With the Joint Commission and other areas really putting the leverage on our executive teams around the term high reliability. When I go to hospitals across the country, almost every single executive team talks about high reliability. But then when I start to assess and get into the grassroots and to the levels of the folks doing the work, and I ask them, what does high reliability mean to you? Most often they don't have the same answer that their executive teams have, or they don't know what the answer to that question is at all. So when you're working on high reliability, or when you're promoting a message, you have to make sure everyone is aware of the message. On the next slide, now that we have our team and we have a strategy, we need to set the project goals, or aim. It's a bit easier with the Georgia and AIM Collaborative because you have a straightforward goal. You're tackling each one of these bundles one by one, hemorrhage or hypertension, and so on down the line. But even with some of the goals already outlined in these bundles, you are going to identify things within your own organization that were not addressed in the bundled strategies. So it's important that your team really sit down and develop a structured project plan. Now, I've found that setting a project plan or an action plan for your team where you clearly lay out each of your steps and a timeline and who's responsible, I've learned that without that, you have a higher propensity to fail because the actions and changes were not clear. Who would carry out those changes was not understood. We didn't know how long these changes would take when we tried to do it without a structured plan. It didn't outline what the resources were needed to carry out those changes. And lastly, it didn't trying to implement an initiative without having a clear communication plan created chaos and eventual failure of projects. So action plans should include the information and ideas that you've already gained while brainstorming. And again, those AIM resources can help you with some of the tips and actions around each of those 4R steps. On the next slide is just an example to include in your project plan. It's a clear structure and accountability matrix. I find it easier to do it this way when working with organizations where you outline what each committee is and what their responsibility will be. It's not like this is the first project you've ever started on. There are a lot of projects going on within your organization. How do these overlap with existing projects? Can you develop an organizational project plan structure that everyone understands and can manage up through the appropriate swim lanes to ensure that everyone on the team understands what the project is and the time frame, what is needed, and what resources will be required. On the next slide, another piece of setting the aim is getting an assessment of current state. If you're using Lean, of course we call that a Gemba, but it simply means visiting where the work is going to be done and walking through every single component of that process and mapping it out. This is a way to gain valuable insight on the flow of your project, and often you will uncover unknown opportunities for improvement. For example, a few organizations that I've gone to, they were very open to doing a hemorrhage drill as if it were a real-time event on their units and let them go through every process that they thought would happen around a hemorrhage emergency. That was part of doing a GEMBO. We were able to see exactly who they call, what their activation strategies might be, and if they were successful or not, what the timing components would be. You have to know all the elements of your project in order to establish a very reliable plan. What works for my organization is not going to work for your organization. My understanding of processes may not be the same understanding as the person implementing the work every day. On the next slide, after you've walked through your plans and you've assessed the need and you've streamlined what you think are your processes, you have to set a clear goal. And I like to use SMART goals as a way to sort of help focus this. It helps us make sure that our goals create a sense of urgency within the organization, but they're also realistic and based on what the evidence suggests is possible. The mnemonic SMART really tells us that our goals need to be specific. You have to define where you're going to end up. What do I want to accomplish? What is involved? Who is involved? Where is it located? Our goals have to be measurable. Must have specific criteria in order to measure your progress. How are we going to know you were successful if we can't measure what it is you're trying to accomplish? And I'll give you an example here. For example, hemorrhage. How many of you can tell me what your hemorrhage rate is in your organization? How much blood you used in the last year to support a hemorrhage? What the complications were around hemorrhage? Most organizations can't answer that question. Do you have what your goals are associated with hemorrhage outside of process or structure goals? Are your goals attainable? They need to be realistic in order to be successful. So you can set goals, and you can set them for varying time frames. But if you can't attain that goal, your team is going to become deflated. Relevant goals. Is it worthwhile? Is it the right time? Does it match our effort? Am I the right person? Who is the right person to help you meet this goal? And your goals need to be time-bound. They can't go on forever. Although process improvement and quality improvement is an ongoing process, the implementation of the core structure needs to have a time frame. As I just mentioned, there are a lot of goals that your organizations are working on, and implementing a particular strategy needs to have a time-bound strategy. On the next slide, we talk a little bit about understanding measurement as a critical part of testing and implementing change. They tell us whether we are actually making improvement. It takes on a lot of forms, measurement. We know that when we analyze, it gives us the ability to adjust the plan, right? On the next slide, there are different types of quality measures that we like to look at. There's structure measures, which are the characteristics of the setting where the care is provided. It provides you a sense of your provider's capacity or systems or processes that provide the care. They help us look at policies that are in place that affect the care that is provided. They might look like the providers and hospitals and outpatient practices around a particular initiative, protocols related to the delivery of care, for example, hemorrhage. A structure hemorrhage may say the availability of your hemorrhage cart. Do you have a hemorrhage cart? Yes or no. That may be the goal of your organization. What are the process measures? Those, for example, would be quantification of blood loss. What quarter of the proportion of mothers had measurement of blood loss over the recovery period, cumulative blood loss. Are you measuring that? That's an example of a process. The outcome is really that claims all payer data that I was talking about, and that's the change in the patient's health status as a result of the care received and as a result of structure and process measures. We have often in our populations omitted the view of outcome measures. I just gave you an example around hemorrhage. What is the national rate of hemorrhage? What is a comparative hemorrhage rate between hospital and hospital? We honestly don't know. But we're being asked that now, and legislation, as mentioned, is going in place to really have us focus on our outcome measures, which is typically claims type data. And then balancing measures, and I'd say the most perfect example of balancing measures right now would be that PCO6 measure that we started to collect in January of this year, the unexpected newborn complication, which really tells us some information around cesarean sections and induction of labor. Balancing measures look at the health system from different ways, and they're meant to identify and mitigate unanticipated outcomes. On the next slide, I've provided you an example. This is an example of a quality scorecard. It's tiny, sorry, but the idea is, do you follow trends? We provide this for our members that are focused on an initiative or through our collaboratives, and it gives us an end goal that all of the other components that we've put in place are successful. And I mentioned earlier, at the end of the day, all of us will be measured on our outcome data. This is going to be part of federal and state law. Do you know if what you have in your outcome data is reliable? For example, and I keep using hemorrhage because I know we're focusing on that as a state, but this applies to any outcome measure in the maternal world or infant world. For hemorrhage, is that number that is being fed to the CDC and part of the CDC severe maternal morbidity rate, is that data accurate? Are you aware that your data is being shared with different organizations? Or what data is being shared? Is it reflective of your actual number of hemorrhage cases? Is it not? It usually is not. Usually providers aren't documenting to the definition, and coders are not exactly abstracting to the definition of hemorrhage. So there's a lot of work to be done in the perinatal population around outcome data, and I provided that to you for an example. Testing your change on the next slide, now that your team has set goals, established your members, developed your measures, you want to test to see if that change leads to improvement. The IHI model works, it's one of the easiest to utilize. It's that PDSA cycle to do that small scale change process. When using this particular method on your project, it becomes a series of small sequential trials or experiments to rapidly test a theory and then refine your idea to achieve the desired outcome. So on the next slide, it's a picture of a driver diagram that's also used to test and identify a change process. It's a great tool for testing your theory towards the desired goal. Think of it as the driver diagram informs us of testing and refining our theory and goals by narrowing them down to defined activities. You can actually see the process of your test of change. You can find examples of driver diagrams in the AIM implementation toolkit, or you can go to the IHI, and I've given links at the end of this slide. So why test change on the next slide? Well, it's pretty obvious. It's a lot less money to do a test of change than it is to implement an entire initiative. The process of testing change is pretty powerful. It's great to learn what works and what doesn't work. It's often less disruptive to your staff and patients when developing change. And when you involve people in the change process, they're usually more likely to accept the change because they feel that they've had input. On the next slide, we've moved to implementing the change. Now that you have essential success factors of an engaged team, effective leadership, a structure with clear aims and measures, you've tested your theory, now you're ready to make things happen, which is actually probably one of the hardest stages that we tend to encounter. The process for change is never easy. It requires a very well-planned strategy for successful implementation. An effective change implementation plan is multifaceted. It targets staff, education, decision support, clinical audits, opinion leaders. All kinds of things are necessary to facilitate change, and your change team has to think through all the different elements. It's challenging to implement change and sustain improvement. Plus, people within an organization adapt to change at different rates. Not everyone's going to accept change at the same rate. A key for striking balance between what is needed to move forward to timely achieving our goals within an organizational level of change is really asking the opinions of those that the change is going to impact. Very often we don't ask, hey, what projects do you have going on before we start to implement these change processes. Very often we don't realize a labor and delivery change is going to impact maybe our decision support teams, potentially a project that the emergency department or the laboratory has in place. We need to make sure when we're putting change in place that we've gotten the buy-in from all the elements that may be impacted. On the next slide, I gave you a few secrets on successful change implementation. That's a survey that went out on barriers to implementation change, and it was interesting that half the respondents say that most or all of their change efforts in the past 5 years met their goals and sustained change over time. Think about that, only half. For probing deeper, the responses showed that the root causes of the failure cluster around 3 critical themes: organizational-wide ownership of and commitment to the change, regular and effective prioritization of the change, and deployment of the right resources and capabilities around the change, which in essence, when you say it out loud, makes sense. On the next slide, there's a change management theory that is most often used to help understand how to improve our ability around implementing change, and it's Cotter's 8-step process. And it's before you really implement that change, it gives us some great thoughts on what we need to accomplish. We need to identify the why for change. You did that for your executive teams. Have we done that for everyone involved? We collect all the leaders associated necessary to guide that change. From the outset, we engage the stakeholders in this process by pulling them together on that steering committee. But have we included all the stakeholders that will be impacted by the rollout of this plan? We developed that strategic vision and plan. We know that to maintain the health of our population served is a big picture, but a strategic roadmap around that needs to be married to that vision. We need to have an internal vision focused around specifics, and it should be set with a plan and a process and implementation for ongoing management of that vision. We need to remove obstacles for change. This is where your leaders can help you and begin to change and track our processes, to ensure that change is sustainable. On the next slide, part of that process and a large component of that process is communication. Of course, we know this cannot be understated. It's the golden thread that runs through an entire practice of change management. Identifying, planning, onboarding, and executing good change management plan is dependent on excellent communication. Again, I go back to that strategic organizational plan developed with your project plan. You can use that as your communication plan. Very often the folks that are involved in that particular organizational structure are the key players related to communication. If not, identify from the onset who is as you roll out this plan. Another tool you can use on the next slide that might help you in successfully communicating your change is the ADKR. Awareness, desire, knowledge, ability, and reinforcement. It's a great mnemonic to use for communication strategies. On the next slide, in communicating strategies, again, you have to circle back to making sure that we have engaged in a shared purpose. Creating that shared purpose starts with the same steps in building consensus in any organization. We have to listen, demonstrate respect for the diverse views. We have to create that process through stakeholders and help shape that vision with the implementation. The IHI has a framework. I kind of put that framework on this slide here without going through every step of the process. But again, listing at the beginning, what is the common purpose at the end of the day? I find that we all, in the end, have the same purpose. We want to do what's right. We want to do what's best. What is it that we are trying to achieve that accomplishes that goal? Sharing knowledge on the next slide is a key element in sharing any implementation strategy. Part of being a high reliability organization requires that we become a learning organization. So what does that mean in terms of establishing that leadership culture and rolling out an implementation plan around learning that culture? Well, it's effective training from the beginning of hire all the way through any change and in an ongoing way to ensure that any change of an implementation strategy is shared with the entire group. Knowledge sharing is critical to organizational success, enhances your team's performance, and provides an organizational with sustainable competitive advantages. Sharing does not always occur naturally. We know that as leaders you play an important role in facilitating that knowledge and getting out what is changing, why it's changing, how it will affect their area, and how it will affect them directly. On the next slide, a quick overview of the importance of team dynamics, whether it's Team Steps or any other team training program you use. It's very helpful, as mentioned, in a lot of the strategies around change management. In Site 2 simulation, as mentioned earlier, is also very helpful around change management. Again, that is using team dynamics and very structured training programs will help that culture of safety and should be an expectation around any organization with a culture of safety. On the next slide, we know you're going to run into barriers. We know there are going to be challenges. It's what you do with those challenges. It's what you do with those obstacles that matter. You have to have a plan A, B, C, D, and E. Include those strategies in your team meetings and talk about any potential or known issues that may disrupt your change process. When it comes to spreading change, spread on the next slide is really just getting this process across the whole system and involves implementation of the interventions in each applicable care setting. A key factor in closing the gap between best practice and common practice is the ability of our healthcare teams and our organizations to rapidly spread innovations and new ideas. Pockets of excellence exist, but knowledge of these ideas and better practices remain in isolation to others. So how do we share? There's some key attributes associated with diffusion of innovation. It's a theory that underpins successful sustainability and spread of improvement. It also reminds us to consider vital elements, what is changing, where, and for whom those changes are occurring. On the next slide, finally, we talk about sustainability. We know that's hard. If it was easy, you know, I would be out of a job, quite frankly. There's no magic bullet, and it's ongoing. I put on the slide how you go back through each and every process. Once you implement a project, it doesn't go away. You do have to continuously measure it. There will be updates. There will be changes along the way. And as a team, you need to keep those in your forefront and make that a part of your plan. I should have started on the next slide with sustainability as the first slide because really it's something that you have to consider when you begin your project. We know that without continual growth and progress, we can't achieve our improvement goals, and success would have no meaning. Again, measurement of our steps around sustainability is keenly important. And lastly, let's celebrate our success on the next slide. Organizations, you guys undertake a lot of work, and sometimes we don't even look at the glass as half full or a quarter full. We should celebrate all wins in the beginning, throughout, and certainly at the end. Our teams can be frustrated. We know that we are constantly asking them to change, and that frustration bubbles up. But if we show them the difference that it's making, for example, the improvement in our outcomes, how your organization compares to other organizations, our teams appreciate this, and it helps drive improvement of the current projects and projects to come. Next slide. There's no magic wand. There's no magic bullet. I wish I had one. It's hard work. At the end of the day, it's a lot of hard work. And it means that the team has to have careful planning, use structured framework, and most of all, have clear goals. That means everyone understanding and keeping the end goal in mind. We can flip to questions if there are any questions. I know I ran a little long, and I apologize, but I'm happy to answer any questions you might have.
Thank you, Deb. That was really great information.